Asher is a patient that I've shared with Dr. Weber, our orthopedic oncologist, and he has really been, I think, a successful case for both of us. When he started off, I know Dr. Weber had initially seen him, and he had been a gentleman with some leg pain, and eventually was diagnosed, unfortunately, with a fairly aggressive osteosarcoma. What was interesting about Asher is that he's basically a bodybuilder, so he would bench press or deadlift or whatever they call it. It was 500 pounds that he was lifting. So I think the challenge for us was certainly, first and foremost, our goal was curing his cancer. He's a young man, he was only 48 when he was diagnosed. But also our goal was preserving his quality of life to the best that we could, knowing that some of our treatments, certainly chemotherapy, certainly surgery, could affect what for him was not only his hobby, or I guess his passion, but also his career. I mean, he works as a personal trainer. So that was really a challenge, and certainly for him, he wanted to cure this cancer and save his life. But he was concerned about side effects and how all of this treatment would affect him. So I think we certainly took that into account. His wife was a nurse practitioner, which is also important because she's in the system. She was able to do reading on sort of good sites and have knowledge about what he was going to be going through. So that was important as well. And I think ultimately helped him as he went through all of this to have her with that medical background. We talked a lot about what kind of treatments to offer, and the goal with osteosarcoma, with these bone cancers, is to try to save the limb, particularly with him, but ultimately, as I said, save the life. The goal for him was certainly chemotherapy and get good control, and typically it's preoperative chemotherapy, restaging with scans to make sure that we're getting a good response and that there's been no spread of cancer elsewhere, and then going to surgery. The goal at surgery is to see what the pathologist will call necrosis, that there's been a good treatment effect, that there's really no viable tumor left. And then assuming there's no viable tumor left, we do further chemotherapy after surgery to really try to get good systemic control. We clearly have gotten local control if that viable tumor is gone, but the problem with any cancer is that the tumor cells can go elsewhere and spread. So our goal after surgery is more chemotherapy so that we know we've really tried to get everything possible. So what's important to know about Asher's case is that he had a primary bone cancer, osteosarcoma, which is a primary cancer of the bone. And again, the goal is cure. It's aggressive therapy. It's usually multimodality, chemotherapy, surgery. And I'm pleased to say that it's now been over a year since the surgery, and he's had no evidence of recurrence. He's back to bodybuilding and weightlifting, a lot of weights, and I know he talks to Dr. Weber, his orthopedic surgeon, about the impact on his prosthesis, because he has an artificial knee, obviously, after the surgery. But from the standpoint of lasting effects of chemotherapy, he really hasn't had any, and he's done very well. He had an excellent response to the chemotherapy, and he had an excellent surgery. But what's important is he had a primary bone cancer, osteosarcoma. Our goal was to cure that. It's really important to distinguish between cancers that start in the bone, like osteosarcomas and any of the primary bone tumors, and a secondary bone cancer, something that is spread from another site to the bones. It's actually much more common, so-called metastatic disease, and common areas where the cancer would start would be the prostate or breast. Really any cancer can spread to the bone, but those would be the two most common that we see, and lung as well. Certainly those are still treatable once the cancer has metastasized to the bone, but it's much harder to cure, and typically our goal is controlling that cancer and dealing with some of the symptoms. Once a cancer spreads to the bones, pain is a real issue, and it's very important when we treat, not only to try to control the cancer and slow it down, but help with the pain. And we often use chemotherapy, and radiation as well can help with that. But they are different, and that's an important distinction. So for this patient, thankfully, he had a primary bone cancer, and our goal was cure, and so far he's doing really very well. So in Asher's case, what really was important was the multidisciplinary approach. Dr. Weber is an orthopedic oncologist, myself as the medical oncologist, of course, it was important to work together. We came up with this plan of care together. And I think it's important to incorporate, the timing of everything, obviously. Dr. Weber has really been very involved in the sarcoma conferences, not just within Aurora, but outside as well. So he's trained outside of Aurora, and he brings a lot of that expertise and some of his connections still to Aurora Cancer Care. So together we came up with a plan for the preoperative chemotherapy, the surgery, the postoperative chemotherapy. And the fact that we here at Aurora Cancer Care have so many different specialties involved is important. Cancer care is not just chemotherapy, it's the surgeons, it's the radiation oncologists, it is medical oncology, of course. It's radiology for that matter, relying on them to let us know what a scan looks like. It's our pathologist. So it's really everyone working together for this patient, and that's an advantage here. We have a comprehensive computer system which we're all on, which also helps. We may not be able to talk to each other every day, but all the notes are accessible, all the lab results, the scan results, and we can all see them, and I think that helps to really give a more integrated approach for the patient. And I think the patients appreciate that. I know Asher certainly did. So.